Bonjour, mesdames et messieurs. Unstable and dislocated lenses are not infrequent findings in our clinical practice, and we do have a lot of challenges in these cases, specifically when we're considering what type of surgery we will do and what type of lens and how we will fixate it in the eye. One of the options is obviously IOL scleral fixation, which can be done as a primary procedure or as a secondary intervention, for instance, when IOL refixation or exchange is needed. IOL scleral fixation techniques are many. They basically can be divided into two major groups, suture-dependent and sutureless. Scleral fixation techniques can be done by providing the needle through ab-internal or ab-external approach, utilizing different numbers of points of fixation, and even sometimes using haptic to suture the IOL to the sclera. This is a more or less classical techniques that was described by multiple authors, starting from Malbron and Lewis. When you create two scleral flaps, mark the area where you will pass the needle into the eye in order to be able to go exactly into the ciliary sulcus, and then you pass the second needle attached to the suture, feed one needle into another in order to retrieve the needle attached to the suture outside of the eye. And then you have two ends of the suture going out of the eye, and then you retrieve the loop, attach it to the haptic of the IOL, and then insert IOL and position it in place. So basically, this technique was used for attaching rigid IOLs to the sclera. This is the ideal position. We can see that the optics is well centered and both haptical elements are located exactly in the ciliary sulcus. However, this can also happen. We see that the lens is tilted. It is not centered according to the pupil, and one of the haptical elements is positioned below the ciliary sulcus, somewhere around the pars plana rather than in the ciliary sulcus. These are possibilities for haptic malposition. We see the haptic outlined with yellow arrow. The left picture when the haptic is placed a bit anteriorly. The second is a bit behind. And the third one, the haptic pressing the iris root, closing the angle. So there are different reasons for IOL malpositioning. This technique is complex and challenging, so you need surgical experience. Sometimes there are blind maneuvers behind the iris, so you really cannot see the ciliary sulcus. There are different anatomical variations of the ciliary sulcus. That's why you cannot always be sure that you are in. And also we can, in some cases, have a pathological changes of ciliary sulcus. Here is the sulcus endoscopy showing that it is not even. You see that the ciliary processes are attached to the posterior surface of the iris, and also sometimes you can see indentations coming from the back of the iris into the ciliary sulcus that make this correct placement of the IOL haptic sometimes quite challenging and not so easy. And here you can observe pseudoexfoliative syndrome located on the ciliary processes. These are the reasons for IOL haptic malposition. We can see posterior senae here. We can sometimes find residual cortical material, especially in cases when we are implanting IOL as a secondary procedure, and there are sometimes capsule remnants. All of these can interfere with the suture passing through the eye. There are certain techniques that help us. This is transillumination technique, when you eliminate the sulcus with the endoscope, and you actually can see the white line which is corresponding to the correct position of the sulcus, and you can actually observe the needle passing through the eye and to be sure that it's located perfectly in the desired place. There are several problems that can happen with the classical techniques. Sometimes there is a transient hypotony because of the leakage, suture exposure, suture degradation, and endophthalmitis. Here is the case of suture exposure. We see that the knot is exposed through the conjunctiva, and it is very challenging because we actually need to repeat the procedure of suturing the haptic and tying it to the suture, which is always a big challenge for the surgeon. Suture exposure rates varies quite significantly. In early flapless techniques, it happened up to 50% of cases. With utilizing partial thickness flaps, these complication rates were significantly reduced. However, still was above the levels that we wanted to be. This is a Hoffman pocket technique, which is I call the new flap technique, because basically you're not creating a flap, you are creating a pocket which is located intrasclerally. And with these pockets, it's much easier to bury the knot and to be sure that it will not be exposed long-term postoperatively. So it's a very, very useful technique. Hoffman pockets eliminates conjunctival dissection. They are useful with filtering blebs in patients after glaucoma surgery. The knots are covered with rotational movement. It allows 4 points of fixation, and it is more comfortable for the patient because there is no wide conjunctival dissection. However, flapless techniques are the next generation of the suture, scleral suture fixation. This is the zigzag scleral suturing, which is one of my favorite, when there is a suture which passes parallel to the limbus 4 or 5 times, and actually the knot is either not being done at all, or it is located at the equator of the capsular bag, and there is no risk of exposure of that knot. Here's the eye after the surgery, and you can actually visualize the blue lines corresponding to the Proland suture, which can be sometimes visible through the conjunctiva. So this is a little bit of disadvantage of this technique that most probably not be very relevant. However, I will not be using it in the younger patients. There are several anatomic considerations to be kept in mind. First, we need wider scleral exposure. For that, L-shaped conjunctival incision is utilized. And also, there is not enough space for suture when the needle exits close to the rectus muscle. That's why you have to consider where you would like to place this Z suture to avoid these issues. Suture degradation is another issue with the suture techniques. So with 10-0 propylene, it's almost 28% of cases in 50 months postoperatively. However, it may also happen with the 9-0 propylene, as we showed in this publication in DGO. This is a 9-0 polypropylene, and you can see on the right picture, right upper picture, that there is a process of biodegradation leading to breakage of that suture that was keeping the modified capsular tensioning in place and fixating it to the sclera. And on the upper left picture, you see the area when the suture was broken because of that biodegradation. Obviously, by utilizing thicker sutures such as 5-0 or 6-0, which was proposed by Canabrava, utilizing flange suturing techniques, it's much more reliable and may provide long-term stability of that implant. Here is the one of the latest publications describing the 5-0 polypropylene used to fixate the aqueous AO lens with the flange sutured technique, which I find quite useful. Gore-Tex is another option, as shown here. It was published relatively recently, and I do like to use the Gore-Tex because it's non-absorbable and it is very reliable type of suture fixation of the implant to the sclera. There are several instruments can be utilized, which is the suture retriever, which I found quite useful, that help to retrieve the Gore-Tex suture from the eye, outside of the eye, facilitating scleral fixation. The novel surgical techniques are also sutureless, and let us describe all these techniques as shown here. First, they were described by Gabor Shariot in 2007, followed by Amar Agarwal, and then by Shin Yamane. The original technique of Shariot is based on externalizing the haptic of three-piece IOL, creating a tunnel parallel to the limbus to introduce these externalized haptic elements. And with that, there is no need for any kind of sutures because the haptic of the lens is located intrasclerally and it is fixed quite reliably. This is the original pictures by Shariot as shown here. This is a blue line representing the haptic located in the scleral tunnel. This is the clinical patient of me, a 16-year-old patient being aphakic because of lensectomy done several years ago. And he was having a very high visual acuity and very good visual potential. That's why I decided to go on with the IOL implantation. This is the clinical case of that patient, and I am now creating superficial square scleral flaps located opposite to each other. And here is the clear corneal incision which I made for introducing the IOL. It is quite important to keep the eye firm, which is done by either utilizing anterior chamber maintainer or by utilizing pars plana irrigation. These are two paracenteses that are made in the deeper scleral layers, and now I'm using 27 gauge needle in order to create two tunnels to be further used for introduction of the haptical elements and to bury the haptical elements. The forceps I use to retrieve the haptic of the lens, which is the leading haptic, and then you need the same maneuver to be done with the trailing haptic in order to pass this haptical element through the sclerotomy. Constant irrigation again is very important, and sometimes you need the assistance of of your surgical assistant in order to hold and grasp the haptical element, so the lens will be stable and sitting in place. Now the main incision is being sutured, and then by placing the haptical elements inside the scleral tunnels, and then by adjusting the length of the haptical elements located inside this tunnel, the surgeon is being able to centrate the lens. You see, this is the second haptical element introduced into the scleral tunnel, and now there is a little bit of adjustment of these haptical elements, and the flaps are sutured in place. So is the conjunctiva, and basically this is more or less the end of the procedure, and we see that the IOL is well centered and located perfectly. One of the issues with that technique is that usually the sclerotomy is wider than the diameter of the haptical element. That's why the glued IOL techniques proposed by Agarwal was quite useful, because it helps us to avoid leakage from the sclerotomy and avoid the hypotony of the intraocular fluid as a result of the leakage of the intraocular fluid. As shown here, here's the area where the glue is being applied to avoid the leakage. However, this technique is not immune of complications. Some of them can be medically treated, such as corneal edema or epithelial defects. Some has to be managed surgically, such as lens decentration, haptic extrusion, and haptic externalization into the subconjunctival space. Here is one of the examples of the haptic, which is located on top of the conjunctiva because of erosion through the two superficial scleral tunnel and through the conjunctiva. Flange IOL fixation technique is very, very popular now. It was introduced starting from 2014 and was well described in these publications in 2017. Basically, the idea of that technique is to create the flange on the tip of the IOL haptic, and the haptic is introduced outside of the eye by utilizing thin-walled 30-gauge needle. That's why there is a very little risk of leakage through this wound, because it's very small and self-sealing, and the bulb at the end of the haptical element, which is created with cautery, as shown here, actually blocks the lens, helps to maintain its position, and also blocks the aqueous humor from exiting the eye. And there is no need for wide sclerotomy and wide conjunctival exposure. Here is the flange IOL with the blue arrow. You will see the location of the haptical element, and this is a haptical element located in the scleral, inside the sclera, which is assessed with the OCT. So there are certain advantages of that technique. There's only very tiny conjunctival incision, no need for wide scleral exposure, no need for scleral flaps, no suture, no fibrin glue, which is cost effective, and it utilizes foldable three-piece IOL that are more or less in a wide use, and they are in our surgical armamentarium. However, we should keep in mind that some three-piece IOLs are working much better than the others, and the difference is in haptical elements, because the PDDA haptical elements are more flexible. They're not so prone to damage as opposed to PMMA haptical elements, and that's why these type of lenses with PDDA haptics are preferred by the surgeons. However, some complications may happen, including IOL dislocation, hypotony, IOP spikes, vitreous hemorrhage. Again, there is a chance for subconjunctival haptic extrusion, cystoid macular edema, and pupil capture. Sometimes pupil capture was quite challenging to manage. However, by introducing peripheral iridotomy and introducing it into the clinical practice, together with the intrascleral haptic fixation, significantly reduced this complication. Here's the subconjunctival flange, as shown here, when the haptical element was exposed through the conjunctiva. Obviously, this case is very challenging because of the possible endophthalmitis. There are several challenges of Yamani technique. First of all, it's technically complex, and it requires experience and certain surgical dexterity. Sometimes there is imprecise needle positioning that is leading to potential IOL decentration, and it's hard to control the needle inside the eye, and sometimes difficult to insert the haptic inside the needle. That's why new variations of that technique, actually, we are going back to flap techniques from flapless techniques, even with the new flange IOL techniques. Here is the Y and T fixation. Again, we see that the haptical elements are located inside the scleral tunnels, and they are covered with superficial scleral layers in order to avoid the exposure. There is an elegant solution to haptic exposure, is actually to create the tunnel when the haptic is actually the tip of the haptic is located not in the scleral pocket, but it goes back into the sclera, and it is located inside the eye. With that maneuver, actually, the haptic externalization chance is minimal. Here's the very useful instruments you show here. Sometimes it's not so easy to insert the haptic into the needle. That's why Michael Amon introduced this forceps needle, which is in two form factors, 27 gauge and 30 gauge. And actually, this forceps needle help you to grasp the haptical element and insert it into the sclera. And it can also be used even with the suture. So if you want to suture the IOL, you can still use this forceps needle. There are also variations when there is a needle with which is attached to microtube, and this microtube is passed through the sclera, and this microtube is used instead of the forceps or needle, because you actually feed the haptical element inside the lumen of that tube, and you are retrieving these portions of tube out of the sclera, which is quite helpful and very elegant. And here is the scleral IOL fixation solution pack by MST, which gives you all the possibilities, all the instruments that you actually need, starting from marking system, MVR blade, thin-walled scleral needles that are very thin and very elegant, needle holders, anterior chamber maintainer, and even low-temp cautery. So this is a perfect solution to this technique, a perfect addition to your surgical armamentarium. So Concluding my talk, I want to give you a couple of take-home messages. So that currently there is a significant variety of techniques for scleral fixation, and which is more importantly, these techniques are improving, including not only the techniques, but also the instrumentation. And it looks like that three-piece IOL intrascleral haptic fixation is one of the most useful today, and it is more reliable long-term than any of the other techniques. However, we should keep in mind that sometimes flapless haptic suturing technique, such as Schurman, zigzag suture, Hoffman pockets, can be also utilized when, for instance, the surgeon is dealing with single-piece IOLs and utilizing the scleral fixation of the capsular supporting devices. Thank you very much for your kind attention. Merci beaucoup.